Welcome to the Resilient Butterfly Podcast. My goal is to share inspiring stories of healing and recovery through many diverse approaches and models. Our guests bring incredible lived experiences, insights, and/or professional expertise, each with their own unique path. While we highlight and celebrate these stories, our intention is to inform, inspire, and demonstrate resilience and creativity. This podcast does not endorse any one approach. We believe there is more than one way to heal, and we're here to showcase the resilience and possibilities that exist. Hello, beautiful souls, and welcome back to another episode of Resilient Butterfly, where we explore the transformative journeys of healing, growth, and resilience. I'm your host, Pam Feinberg Rivkin, and today I'm honored to welcome a truly inspiring guest whose work is reshaping the landscape of trauma recovery and mental health. Joining us is Dr. Chantel Thomas, a clinical psychologist and the executive clinical director of Windrose Recovery and Integrita, two leading addiction treatment centers in Wisconsin. With a PhD in clinical psychology and over a decade of experience in trauma-informed care and psychedelic-assisted therapy, Dr. Thomas is at the forefront of integrating science, compassion, and innovation in healing. She's also a certified practitioner in MDMA and ketamine-assisted psychotherapy and has contributed to groundbreaking research with FDA-regulated trials for PTSD. Dr. Chantel, thank you. Welcome to Resilient Butterfly. I really appreciate you being here. You have so many words of wisdom to share with the audience, and the audience is here in the U.S. and some otherwise in Australia or UK or Ireland, because I have guests that are from those areas as well. So with that said, I want to start with your personal story of why you are doing what you're doing, what brought you into the work of trauma and recovery.
Yeah. Thank you so much for having me. It's a pleasure to be with you and to talk about this. My father is an addiction medicine specialist. He was actually one of he was part of the first group of physicians to be licensed in the specialty of addiction medicine in the country.
Oh, wow.
Which he loves to tell me about.
Mm-hmm. That's great.
If that tells you anything about him. But what that means is I was kind of steeped in the language of psychology very early on. I think my dad had a very innate curiosity about human behavior. And even though he wasn't in recovery himself, as a family medicine physician, he seemed to have a knack for working with folks who struggled with substance use issues. And I think it's because he's a very interesting blend of personable. He's very personable.
That's where you get it from.
And he's also, he's from South Africa. My family are from South Africa. I was the first one born out of the country. I was born in Canada. And he has this disarming, almost shocking kind of ability to say difficult things to people in a way that doesn't feel hard to take in. Mm-hmm. And I think that combination of like kind of radical transparency and authenticity and maybe a little bit of arrogance at times, like really allowed him to feel like a trusted person in that area for a lot of people who are struggling with addiction. And I've always really respected that he has never looked down on people struggling with substance use disorders as less than, but I think he had a real fascination with that, the people that get into those painful cycles, and also saw that there was a real need for that in medical care to be able to have those conversations in your primary care home.
Absolutely.
So,
my stepson is a family medicine, and he went into addiction medicine. So
cool.
I'm going to make sure that he watches this episode for sure.
Yeah, my sister ended up being a family medicine doc and also specialized in addiction medicine. And then my brother's an orthopedic surgeon. So I think it was definitely in the family soup. I think at one point in time they had decided that I should become a lawyer who specialized in medical law, and I declined that invitation. But so I heard him talking about it very early on. I think I got curious about it. And then when I had the opportunity, I wasn't exactly sure vocationally what path I was going to take. I studied English literature in undergrad, and I was a Spanish minor. I was very interested in philosophy. And then after I got done with my undergrad, I started to get curious about going to grad school for psychology, and ended up getting my doctorate in clinical psychology with a specialization in health psychology. But my love for working in residential environments, and that's kind of that 360 view of what's happening for people, in addition to just like a lot of appreciation for what I believe are the most sensitive souls in our culture,
Mm.
right?
Mhm.
People that end up being drawn to substances to kind of survive the pain of unfiltered sensitivity alongside of this ability to kind of see parts of life and society that maybe other people may be not tuning into. So artists and poets and musicians and
Mhm.
big personalities.
Mhm.
And so I really felt a really strong kinship with that type of population. Um, and then of course, my first love of my life turned out to be a methamphetamine addict, unbeknownst to me, consciously.
Really?
Yeah. So,
How many
um,
years ago was that?
oh gosh, over 20 years ago. Yeah.
And how long were you with him before you realized?
Oh man, I was with him for quite a while. I grew up in a very conservative religious environment, and I had very little exposure to drugs or alcohol. I was a Seventh-day Adventist in my family, so no one drank when I was growing up, or not for recovery reasons, but just it wasn't part of the culture.
Mhm.
So I was very naive to like what drug use looked like, or even what excessive alcohol use was like. I didn't have that kind of environmental social curriculum to understand. And my first, yeah, love of my life my very first love, was this real big personality.
Mm.
Um, and it was completely, I had no idea what was happening. it was, it was completely baffling to me. And it released all these instincts in me around, what would be classically called codependency.
Mm.
Um, and it was a brutal, really painful journey from the inside out without having
Sure.
struggled with a substance use disorder myself. So I got a lot of respect and reverence for the systemic way in which addiction impacts everyone, including the
Yeah.
person who's suffering.
I just was recording with Steve Feldman
Oh,
before this morning, and we were
yeah.
talking about the family and how
Mm.
this is not a sole situation. It impacts a family tremendously,
Mhm.
and
Mhm.
relationships, and you
Yeah.
had a lot of education unknowingly,
Yeah.
um,
Absolutely.
experience.
And the shame. Oh my God. I remember like the desperation knowing that this thing was so much bigger than me, and just all the attempts to control it and hold on to it and somehow manage it, and just the horrific shame that went alongside of that it was leveling.
And how many
It was
years ago was
leveling.
this?
This was back in probably over 25 years ago.
Mm.
This was in the early 2000s. Yeah. While I was actually working my first job as a volunteer at a addiction treatment center in Malibu, California.
Oh, wow. Yeah.
And it was such a great and baptism by fire to work in a addiction treatment center while I was watching his behavioral spiral out, and recognizing just by being in that milieu, okay, yeah, this thing is way bigger than me. And how am I going to take care of myself? Because thank God I was drawn to the work, because the insanity of it was just terror. I was no match for any of my previous skills.
Sure.
Yeah.
It is not something you can prepare for.
No. Mm-mm.
And in the relationship, at what point did you and how did you, what was some of the things that you recognized? So listeners can, families can hear
Mm-hmm.
the chaos that they may be in and not really know why they're in that chaos.
Yeah, I mean, I think I think what's so painful for families is basically like if things just didn't make sense, like the stories didn't make sense, you know? The I so badly wanted to believe what he was saying, but none of it made it, the story just kept falling apart. And the end result, this I'm sure that I know this was not his intention because we actually became good friends later. I care about him very deeply, and he actually went through testicular cancer, and I supported him through that journey with a lot of his friends in the 12-step community. I felt like I was losing my mind. I questioned myself because I just so badly wanted to believe his story. And so I guess a piece here is just like, don't keep ignoring the signals that let you know that something isn't right. And I think sometimes when we really love people and care about them, we so badly want to believe that things are okay when they're not, that you learn how to disregard every part of your own wisdom and instincts in the service of trying to hold up a story about the person that just doesn't fit anymore.
Yes. And be able to take care of yourself and learn how to break away from that to take care of yourself. So the other person can actually take care of themselves and get well at some point if they decide, if they choose to. There are ways, obviously, that families can, because we work with an intervention and getting them somebody to treatment and that process. And sometimes it works and sometimes it doesn't work. So it is not a guarantee on anything.
Yeah.
I want to switch a little bit in your interest in over a decade of working with psychedelic research for trauma, for PTSD. And what have you found? What drew you to that? And there's so much here for listeners to hear.
Yeah. So I worked in residential treatment environments very early on, volunteering, and then kind of working my way up the ladder into being a program director all the while I was getting my doctorate. And then I finished up in my internship and fellowship at the University of Wisconsin-Madison. So they had a health track fellowship, an APA health track that was about embedding in the level 1 trauma hospital that they had there, working with people with, really significant medical traumas. And then from my work there at UW-Madison, I started working in community behavioral health settings as a fully integrated behavioral health consultant for federally qualified healthcare clinics. There were 3 of them. One of them was a training site for the family medicine department, and I connected with an individual named Dr. Randy Brown, who's incredibly well-known in the addiction medicine world. He's the director of the fellowship at UW-Madison and does a lot of work on health implementation and public health, reducing risk for folks with substance use disorders and community-based outreach work. And then an offshoot of that work, when I was working with Randy in those settings, we both connected because of the piece of substance use. We both loved working with substance use disorders, and we created a clinic within the primary care health clinics that specialized in substance use treatment called the Health Promotions Clinic. And he came to me one day in I think it was 2012, and said, hey, they're doing a trial at UW-Madison on psilocybin, magic mushrooms. Are you interested in screening participants as a clinical psychologist for this trial? And I immediately thought, I know nothing about this, but this sounds really interesting. And I think my whole life I've loved the idea of juxtaposing things that don't seem like they belong together. Like the idea that we would be studying psychedelics in the School of Pharmacy at the University of Wisconsin in Madison just sounded like those two things don't necessarily
Right.
belong together. And those things always really fascinate me, those intersections. So that's how I got involved. And my husband at the time was not my husband, he was my fiance. And he is also a clinical psychologist and a neuroscientist. And neither of us were versed in psychedelic work. And I brought Chris on board, Chris Nicholas, and he and I became the screeners for that trial. And as a result of that, we were trained in a facilitation model for essentially psychedelic assisted therapy, for this high dose pharmacokinetic study. And the folks from Johns Hopkins, which was Bill Richards, Mary Casamano, at the time, flew out and trained a group of us to work with psilocybin, essentially. And that was we started that in 2013. And it was just this fascinating experience watching people in a therapeutically supported environment, if they chose to go inward with the non-ordinary state occasioned by this psychedelic, in this instance, psilocybin. And this was a non-clinical population because this was really about studying the physical safety of this compound, through physiological markers like drawing blood and blood pressure, et cetera. But watching the ways that folks would kind of deep dive into their psyches and the amount of emotion that would come through and metaphors and kind of the depth of the places that they went to, I walked away from that trial thinking, how can we not be using this as a therapeutic tool? Because, man, I mean, people, in my experience, I think we talk a lot about resistance in patient populations and defenses and all of that. And that's fair. It's reasonable. It's understandable to talk about it in that way. But so much of the time, I feel like when I encounter patients, they really, really deeply want to get better. But even when they're highly motivated, parts of them just cannot soften back. And it really prevents them from going to the places that need the most attention or the most care or that need to be revealed, because our psychic structures of adaptation and survival are very hard to penetrate through some of the typical tools that we have. Not to say that we don't have tools that are very effective, but what if we have more? And what if this was a way to help people from the inside access more?
Sure.
And that's kind of where it all started. I worked with psilocybin, and then in 2015, I got certified to work with MDMA, mitoamphetamine, in the MDMA assisted therapy trial for PTSD. And I worked on that trial again alongside of my husband for 8 years. And then I became a supervisor for that work. I'm still involved with supervision and consultation in that regard, specific to mitoamphetamine. And then I started working with ketamine in 2019 in an outpatient basis in a clinical setting. So I've kind of worked my way through the compounds over time, and just seen tremendous things about the potential utility across diagnostic indications and also across different compounds and the subjective effects that they occasion. This is a very interesting time to be a clinician and to be studying this type of research and really exploring what's possible when we have medically monitored, really well screened, psychologically well prepared participants interacting with these compounds in ways that can really catalyze and deepen a therapeutic process.
Sure. So if you could talk about what of those substances, those drugs that psilocybin, MDMA, ketamine, what are those that are FDA approved yet?
Sure. Yeah.
And how are they used that are therapeutically safe for people?
Yeah. So psilocybin right now is actually marching towards the new drug application timeline, which is what needs to happen for a drug to get approved by the FDA. As a new drug application has to be submitted. And there have to be phase 1, phase 2, and phase 3 trials that demonstrate efficacy. And psilocybin is being studied by 2 large drug sponsors. One of those is USONA, and the other one is Compass. And they're both looking at the treatment indication of depression. And I suspect in 2026, 27 is when the FDA will be looking at psilocybin as a compound for potential approval. For depression. MDMA or midomethamphetamine went up for approval 1 year ago, August, and that was based on the results of the phase 3 trial. There were 2 of them for PTSD, and the effect sizes and the treatment outcomes were pretty staggeringly positive. And I think at the time, Lykos, which was the drug sponsor, was feeling really hopeful for approval because I think something like 68% of people no longer met criteria for PTSD at the end of the trial, which is quite a staggering number. The dropout rates were very low. It's a very intensive therapy in the MDMA-assisted therapy. I mean, up to 40 to 60 hours of therapy with 2 individuals, 2 trained mental health clinicians, kind of working on these distinct dosing session periods with midomethamphetamine, which last up to 8 hours and are really working on trauma reprocessing. But there were concerns raised by the FDA. They actually submitted an open letter for the public to read. Some of the concerns were that there needed to be better tracking of adverse events, but primarily positive ones, because they want to look at if these drugs occasion people feeling really good, is that potentially increase the likelihood of people misusing them potentially? And so they wanted more tracking of that. I think they also had some concerns about whether or not the population could be effectively blinded, which is a necessary condition in research, but very difficult to do with all psychedelics. And that's the idea that if you're getting a placebo or even an alternative compound that's not midomethamphetamine, that it's pretty easy for people to figure out whether they have it or they don't. Although what's striking about the MDMA-assisted therapy outcomes, those that involved a placebo versus those that included midomethamphetamine, that even people in the therapy-only arm, a certain percentage of them had a reduction in their symptoms, and some of them lost their diagnosis. So there's also something therapeutically really interesting about the model that's being used alongside of that compound, which I've come to appreciate as a very non-pathologizing, humanistically influenced. I think about people like Rogers, Goldstein's concept of organicity, which is the idea that humans are inherently whole individuals that move toward wholeness when being given optimal conditions for healing. And that's one way to think about how these compounds interact with people who have a lot of suffering or challenges or symptoms, is that if they're given environmental conditions that optimize their ability to tune in to what's needed inside, and maybe these compounds amplify those messages or instincts or intuitions internally, give them a little bit more spaciousness to explore new perspective, access more feeling. Because if you look in across all these psychedelic trials, it's not about feeling less, it's about feeling more, which is a really interesting paradigm shift from a lot of our psychopharmacological agents were about clipping or reducing affect. And so with midomethamphetamine, you see people in some ways being resourced to feel good enough inside to spontaneously move towards the traumatic events and reprocess them in a new way, which is We still don't fully understand it, but no doubt it has to do with the serotonergic and oxytocin cascade that increases openness and sense of connectedness, pro-social behavior, and reduces some of the fear in the amygdala region. How do all those chemical factors combined with a very, very optimized therapeutic environment that operates from a place of non-judgment, relationally driven, supportive, providing corrective attunement. How do all those things fit together to maybe really make a substantial impact on treatment-resistant PTSD? Because I think most of the people that were in the trial in phase 3 had their diagnosis for at least 15 to 17 years. So folks who tried a lot of other therapies without effect. So MDMA did not get approved, but it's now in revision due to some of the concerns about the way the protocol was written and the information the data that was gathered, some of the more public commentary questions were about the model that was used, and some people in the trial really, really struggled, most often struggled with the ending of the trial, the transition out of the trial in many instances, because they felt like they couldn't have access to a 4th session or a 5th session, and they might have needed that on some level. And also the intensity of the work, the depth of the attachment to the therapy team, and then that ending at the end of the trial was quite difficult for people with a lot of a relational attachment trauma. Sure. No big surprise there. So Lykos, which has now become Resilient Pharmaceuticals, is going to try to they're reinvigorating their. Say it again.
You said Resilient Pharmaceuticals?
Like the name of your podcast. Yeah, I was noticing that. Yeah, Resilient Pharmaceuticals is now going to take another launch at how they might obtain approval as a new drug application for methamphetamine, and that more will be revealed around that in the next year or two. But everyone thought they were going to be the first one to cross that line. But the drug that very first did, technically not as psychedelic, and neither is methamphetamine for that matter. It's more classified as some methamphetamine is classified as an entactogen. It doesn't have pure classic psychedelic effects, but it definitely has altering properties. Ketamine, also not technically a psychedelic, but has psychedelic properties depending on dosage, did get approved by the FDA in the form of Spravato. And I believe that was in the early 2020s. And Spravato is a nasal form version of ketamine that got approved for treatment-resistant depression, and some insurance companies will actually authorize that, and that's been around for some period of time, and so that is actually available. Off-label, ketamine is available at infusion clinics or in the form of a lozenge in the context of psychotherapists who decide to practice ketamine-assisted psychotherapy. But to be honest, ketamine world is quite unregulated in many ways. And so there's a very wide range of variability in terms of how it's implemented, what the process of screening looks like, who's a good candidate. All of that is being very much determined by kind of the discretion of whatever clinician is prescribing. If you go the Spravato route, there's more specific medical factors that they're tracking, and they're looking at failing out of other drugs first before you can trial something like Spravato. But what's also very interesting about Spravato, that nasal form of ketamine in the marketplace, is it's looking at it as a psychopharmacological alternative in a pure medical model. So it's really under-emphasizing the role of psychotherapy alongside of it. And it's also not treating these subjective effects occasioned by the Spravato as in and of themselves inherently therapeutically meaningful, which is a complete opposite side of how psilocybin is being viewed, how methamphetamine is used or viewed, and how many therapists who are excited about working with these psychedelic compounds, other ones to be named are Ibogaine. There was a massive grant that was approved, funding for, I believe it's like $60 million of research in Texas for Ibogaine for addiction treatment. Ayahuasca is another compound that's studied much earlier in the research cycle that tends to be studied in indigenous communities, not in the United States. If it's happening here, it's in churches that have been designated or underground, not in legal containers. And then there's 5-MeO-DMT, which is another compound. Wow. So there's all these different compounds kind of coming to different places of whether or not they're getting close. But I imagine what we'll see is maybe psilocybin might actually cross that line, and then maybe metamphetamine might cross soon thereafter. And then I think 5-MeO-DMT is probably the one that's closest behind that, several years down the line. And then we're going to continue to see more and more of these compounds kind of circulate more regularly.
So I'm going to go back to
long response to your question.
Yeah, there's a lot of information. Wow. And I want to go back to where you say the ketamine, it goes into, ketamine is actually prescribed or given in infusion clinics and therapeutically dosed, et cetera, in wide range of areas. What is the most effective way to provide ketamine-assisted therapy versus going to an infusion clinic? Tell us the difference there.
Yeah. Well, so the interesting thing is we need more studies that if you're purely looking at treatment outcome, right, symptom reduction, there's not great head-to-head studies at looking at if we just administer ketamine as a drug and we do no therapeutic preparation and we just look at it as like some bizarro Prozac alternative, let's say. And then we put that head-to-head with a clinical trial that looks at ketamine being administered in the context of a therapeutic setting. How do those outcomes look? How are they different? The research is coming on that. There have been trials that looked at ketamine-assisted psychotherapy in different contexts, but I guess what I would say, it's not as much about efficacy for me as much as the safest, most ethical way to practice with ketamine. And by virtue of that, I also think it's, in my mindset, the way I determine efficacy, which is not even so much about complete symptom reduction, but my goal when I'm working with clients is to fundamentally shift their relationship to their interior in a way that allows them to trust their feelings, welcome them in as valuable messengers of unmet needs, develop a more comprehensive relationship with their instincts and intuitions, and also appreciate that many times symptomatology, even from something like depression, is our systemic attempt to survive something that's unsurvivable. And that's not to discredit organicity's role in depressive disorders, but for me, because the state that is occasioned by ketamine, the non-ordinary state, then I have to also qualify low dose ketamine versus moderate dose ketamine versus higher dose ketamine is fundamentally a different drug. So if you are to administer a lozenge of ketamine in the lower dosing range, the subjective effects that you feel are almost unrecognizable from an infusion of a high dose ketamine in a infusion clinic or even an intramuscular injection of ketamine. So the drug effects themselves change depending on the dosage and the route of administration. But another thing that drastically impacts the subjective effects is the mindset of the individual taking the compound. And that is where I believe the work of rigorous informed consent, psychological preparation sessions, which could be anywhere from 2 to 3 hours to up to 9 to 10 hours or even longer, depending on the individual. I feel like there's a real privilege and responsibility to act with caution and with respect when we are able to move into deeper states of consciousness that are not normally available. How are we going to work with those states in a way that doesn't feel exploitive or overexposing in the same way that doing trauma work with someone, trying to do exposure work or even EMDR when someone hasn't been fully resourced inside feels reckless and dangerous. I think the same thing is potentially true about ketamine. And so for my intents and purposes, I also don't want to just over-idealize the compound itself as the great answer, but I'm actually really interested in how do we set up a therapeutic container that sees this as an amazing tool, but ultimately we center, focus, agency, and locus of control on the individual experiencing it and less on the drug kind of like happening to them.
Got it.
Does that make sense?
Yes, absolutely. Absolutely. I think what I'm going to say to the listeners is do your own research and reach out to those that are certified in treatment versus going to a down the street clinic to get you
Yeah.
in?
And I'd love to empower people to ask questions. Like, what if I have a really difficult experience? How are you going to handle that in the clinic? Can someone sit with me if you do go the infusion route? How do you make decisions about the dosage that I receive? And a lot of times they'll say, oh, well, it's been well studied that 0.5 mgs per kg is the way to go. But then, what I want to ask is there any room for individualization based on the patient needs? And then the other piece is, what is the role of integration? Those are the therapy sessions that follow a ketamine experience. And so don't just assume, because people keep talking about the research, that it's going to be a safe experience for you. You want to look at ketamine administration the same way you would look at developing a therapy relationship. And if you're feeling rushed through the consult and you don't feel permission to ask questions and they're just telling you things that don't entirely make sense to you, there's real implications for going this route and unpacking some of this content that's been maybe a little bit under the surface or buried for very good reasons. And you want to make sure you have a good container to work with what emerges.
Absolutely. I want to move into the your book that you just published, or how long ago did you publish? Thoughts While Listening is such a beautiful reflection on healing.
I think you're giving me credit for writing a book that I didn't write.
Oh, wow. Okay. Well, when I did some research, something came up as a book, but you didn't write it. It sounds like a really great
I'm
book.
fascinated that there's someone out there named
Thoughts While
by
Listening.
me. I love it. What's funny is I've been
I also believe that you could write such a book because...
I feel like you maybe had a premonition. I've been talking about writing a book for the last year, and I was kind of like listening with piqued interest about this topic, about how to seek out kind of novel healing experiences in a very ethically informed, kind of patient empowered way. And also what my experience has been, just watching the range of implementation and what is the role of these compounds potentially for the treatment of addiction, because there's a lot of promising things that might be coming through that pathway as well.
Yes, and just a little bit on that. For someone, because ketamine can be an addictive drug.
Yes.
And a lot of addicts will experiment with psychedelics, not for treatment, but for recreation. And how do you work with someone who actually has an addiction and be able to work with the trauma, but yet not get them back into that cycle of addiction?
Yeah, that's a great question. So first of all, I want to give a shout out to a colleague that I know named Kevin Franciotti, and he actually started a program called Psychedelics in Recovery. And it's literally a 12-step friendly, aligned program that is about using psychedelics in a therapeutic, intentional manner to support a recovery process. So those are groups that happen around the country, and I think online. Again, Kevin Franciotti, I interviewed him on my podcast, actually. And I think it's important to speak to the idea that this psychedelic work can actually be very harmonious with the idea of 12-step recovery. That being said, I do see a lot of people that come into our treatment center, and they have used psychedelics as a way to, I think in many ways, there's been a curiosity about shifting perspective or getting a new vantage point, or maybe even sometimes just to have an experience. And these compounds in and of themselves are not inherently therapeutic without complexity. So the container that happens in matters greatly. And I'm going to talk specifically about ketamine because we started integrating it into our trauma reprocessing program here at the Manor starting in 2020. We do not provide it to all of our clients, but what I would like to underscore about ketamine, it's a great amplifier. So if you use it in a recreational or party-based setting and your goal and you're using it in the setting of other drugs and you're using it to really escape yourself, if you take enough of it or you take it in the wrong setting, you really can disconnect from yourself. It's actually classified as an anesthetic dissociative. So you dose it into a range where you can literally disappear or drop into a K-hole. Some people feel like that's the goal. Some people feel like that's their worst nightmare because it involves ego dissolution or ego death in that kind of instance. But what we've learned about working with it is if you're using the lower dosing range of ketamine alongside of a therapeutic preparation process in an individual that has already started trauma reprocessing work and has done the work of resourcing and safety setting and become more connected to their own feeling world, what can happen is that people actually get this ability inside via the subjective effects of ketamine to feel safe enough to kind of go more deeply into their trauma. Now, if they haven't been taught how to kind of go within, and there's not a really strong therapeutic container relational alliance, what can happen is that people will feel the subjective effects of the medicine and they just want to kind of go away from themselves. And I believe that process of initiating kind of how are you going to work with this state requires a lot of therapeutic support, particularly in individuals who are very practiced in escaping or going away from themselves. And what we found is when we do it as part of a really rigorous protocol and we're on the same page about what our hope is. And so maybe there's a piece of suicidality or shame that is just unsurvivably impenetrable, maybe within the context of ketamine-assisted psychotherapy within our environment, that might provide enough resource inside to look at that differently, to digest it, to provide relief around it, to kind of undissociate from certain intellectual patterns or processes. It allows people to get some help inside, reconsolidating and reconceptualizing that stuckness or that kind of block or that part that wants to die because it doesn't believe there's another option. And so with a lot of therapeutic container and skill, it's an incredibly powerful medicine. But I have a lot of concerns about people with patterns of using substances somewhat problematically, going and having an experience, let's say, in an environment where they're not being therapeutically supported because of all the things that I outlined previously.
Well, this has been very, very interesting, educational for sure. And I hope the listeners gain some information so that they can look more deeply into this. How can anyone get in touch with you and or the treatment that you are the clinical director?
Thank you. So we have a website called Windrose Recovery. And on that platform, we talk about our residential treatment program called The Manor, which is essentially a 6-week program for trauma and substance use disorders. And then we also have our outpatient ketamine-assisted psychotherapy practice called Integrata. That's also located on the Windrose website. And that's where people might come for intensives with ketamine-assisted psychotherapy. We use an emotion-focused, attachment-driven somatic model for working with ketamine that can happen over the course of 3 to 5 days for people who fly in and decide to do an intensive. And then we do regular outpatient work on that front as well. We also have our sister program, which is Positive Sobriety Institute, which is located in Chicago for impaired professionals. And then there's also my podcast called Blind Spots, which is exploring what we cannot see. And there's a number of different podcasts on there that I've done that talk more about our model of working with ketamine-assisted psychotherapy and other, talking about other psychedelic goings on or happenings in the world and speaking with a number of experts through that space. And those are good pathways.
Very nice. Thank you so much for the time that you have provided to us today. I appreciate you, and I'll see you in a couple of weeks in Michigan.
Sounds great. Okay. Good to be with you. Thanks so much.
Thank you for joining the conversation today. If you are seeking help for yourself or a loved one, please reach out to our Feinberg Consulting team at 248-538-5425. That's 248-538-5425. And check out our website at feinbergcare.com. I'm grateful for our guests and all who have joined us today. Make sure you follow us on Apple, Spotify, or anywhere you listen to podcasts.